Hello, it's Dr. Christian O'Neill. This video is going to be about how staff of 3.2 withdrawal management programs should complete the substance-specific withdrawal scales. So before we get to the scales themselves, I just want to talk a little bit about why we use the scales. So scales are intended to assess the severity of withdrawal. And as you know, the different substances of abuse have different withdrawal syndromes associated with them. You know, the alcohol withdrawal is not the same as opioid withdrawal or stimulant, methamphetamine, cocaine withdrawal. Benzo withdrawal is very similar to alcohol withdrawal. So we have substance-specific scales that we use. We have one that's just for alcohol. We have one that's just for benzodiazepine. We have one that's just for opioids. And then there's one for stimulants. So the stimulant scale does double duty. It's for methamphetamine and cocaine. So there are going to be times when people come in and they're polysubstance abusers, and you know, they may be withdrawing, they may be initially intoxicated and then withdrawing from multiple substances at one time. So, you know, some people would suggest that whatever substance they're withdrawing from, you should do that scale. So you could potentially be doing 3 or 4 scales on one person, but there's a lot of overlap between the syndromes, and it really doesn't give you, it confounds the issue when you have too much information. So what I recommend is that we just do one scale per person, and there's a hierarchy of severity of withdrawal that guides us in our decision as to what scale to use. So the most severe withdrawal syndrome is alcohol withdrawal. That's the one withdrawal that can actually be fatal. People can have DTs, which if it's untreated is fatal in about 1/3 of people if they try to go through DTs at home, for instance, or out on the street. So alcohol withdrawal is generally considered to be the most severe withdrawal syndrome. Of course, they can also have a withdrawal seizure. After that, the next one really is benzodiazepines. Benzos the pharmacology of alcohol and benzodiazepines in the brain is very similar. So benzo withdrawal can be very severe and it can be protracted. It can go on for quite a long time. Clients can definitely have a seizure from withdrawing from benzos, which can be very serious. They could have a fall and injure themselves when they're seizing, or they could have a prolonged seizure. It's called status epilepticus, and that can be very damaging to the brain. But benzo withdrawal is typically not as dangerous as alcohol withdrawal, just because people withdrawing from benzos don't go into DTs. So again, alcohol is the most severe because of the possibility to go into DTs. Then you've got benzodiazepines. The next one is opioids. Now, opioid withdrawal, I've never gone through it. I've seen it. It's horrible. I'm not diminishing it, but it's not generally regarded as being fatal. There are extreme cravings, extreme nausea, vomiting, diarrhea, muscle aches, profuse sweating, but it's not really considered to be fatal. People could get in trouble if they're throwing up, they have diarrhea so much that their electrolytes get out of balance. That can happen, but generally it's just incredibly unpleasant, but not life-threatening. And then the last one are stimulants. And stimulant withdrawal really is almost not even a clinical syndrome. Stimulant intoxication can be very dangerous, cardiac arrhythmia, stroke, those sorts of things. But withdrawing from stimulants, coming off of meth and coming off of cocaine, there are symptoms, anxiety, fatigue, cravings. There are symptoms, but stimulant withdrawal is just not considered to be a clinically significant syndrome in terms of the client actually getting into some sort of medical danger. But nonetheless, we're still going to use a stimulant scale because we're going to apply a scale for everybody, and it's going to give us an idea of how long they need to stay in withdrawal management and when they're going to be ready to go to residential. So again, the primary reasons to use these scales are to assess the severity of withdrawal, and then to guide our decision when they're ready to transition to a different level of care. And I'm going to give some guidance for each of these scales, because in terms of when they may be ready, because stimulant withdrawal, usually about 72 hours, they're going to be okay to go to residential. Alcohol withdrawal, could easily be 5 to 7 days. Benzo withdrawal can go on for much longer, actually, but the most severe part of it is probably somewhere between 5 and 14 days, somewhere in there. Opiate withdrawal for short-acting opiates, usually a week, could be up to 10 days. If it's a longer acting opioid like methadone or buprenorphine, it can go on longer than that. Yeah, that's basically kind of the overall picture. Like, why are we doing these scales? To keep an eye on the severity of the withdrawal and to see the trend. Is it getting worse or is it getting better? And that helps to drive our decisions in terms of how long they're going to be staying with us. Trying to think what else I want to say. Oh yeah, so some of the scales you might be familiar with in the past, the CEWA and the COWS, and both of those are clinical scales. They're really designed to be used by medical professionals, usually like an LVN or up. LVN, RN, nurse practitioner, MD. So in our non-medical withdrawal management facilities, 3.2, I'm the medical director, but it's more of a high level overview. I'm reviewing the paperwork that's coming in, and I'm here if you need me. There's questions about medication and stuff like that, but we don't have 24/7 medical staff. And so the CEWA scale, it requires that vitals are checked, blood pressure, heart rate, that sort of thing. Some of the other questions have a lot of medical jargon in it, and it requires that the person administering the scale really be a keen observer of tremors and sweating, and then they have to quantify the severity of that. And the same with the COWS, the clinical opioid withdrawal scale. It's really designed for a medical professional. And CEWA in particular is actually designed to be used in an inpatient hospital setting, and it drives the administration of Ativan for severe alcohol withdrawal. And that's not what we do. We're not making decisions on how much Ativan to give someone. They may come in with an Ativan prescription or a Librium prescription or a Valium prescription, but we're just going to make it available the way it's prescribed. We're not actually making those decisions. We just follow the prescription. So that's why I recommend using subjective scales. And by subjective, I mean that all of the reporting is coming from the client. The staff of these 3.2 programs really just needs to give the client the scale and let the client decide on the severity. There's have 10 to 15 symptoms on the different scales, and they make the selection on, is it mild, moderate, severe? And that's the primary role of the 3.2 counselor. Make the scale available, and the client does all the reporting. Again, as opposed to CEWA and COWS, when it really is the subjective opinion of the profession, of the medical professional. They're the ones that are ranking the assigning the scores. And with these subjective scales, the client selects the severity. And the counselor, there may be some issues around language and reading and those sorts of things. So the counselor can definitely participate in it. If the client doesn't understand the question or has a reading impairment, you can be helpful. But ultimately, these subjective scales, the scores are based on the subjective assessment of the client. Okay, and I hope that makes sense. We're taking out the need for the employee, for the counselor to make these decisions, and we're letting the clients self-report. Now, sometimes with the subjective scales, it can give you a very wide range because some people overestimate their discomfort sometimes. So, I've seen scales that are really high scores, and I'll call the program and I'll say, I'm concerned about this. How's this client doing? They'll say, oh, they're in the day room, playing backgammon. But if you look at the scales, you would think that they were, on the verge of going into DTs. There's nothing we can do about that. We can't the clients get to pick the scores. But if I do reach out to you and ask for your clinical opinion, then I will really appreciate that. And you're a professional, you've been in the field. And if you tell me, you know what, they're not in trouble, they're doing okay, even though the score is really high, then I'll be more reassured. But nonetheless, it still gives us important information. So I think that's what I want to say about it right now. And I think seeing the scales will help you understand what I'm getting at. So let me pull up this first scale. Okay. So this is the stimulant withdrawal assessment scale. Okay, and again, we're going to use this for methamphetamine and for cocaine. We could, if someone's primary was PCP, we could use it for PCP. We don't see that as much anymore. See it in San Jose sometimes. It sort of seems to cluster around certain urban areas, Los Angeles, San Jose, Washington, D.C., Philadelphia, Baltimore. There's some places where there's still a lot of PCP. We don't see it as much like over in the East Bay, but I'm sure if you've been working in the field long enough, you've seen people, that's their primary. So we could use it for PCP. We could use it for MDMA, right? For Molly, could be used. Again, that's not the primary drug for most people. So for the most part, the stimulant withdrawal assessment scale will be used for cocaine, crack, and methamphetamine. Okay, so it just starts out with client name, date of birth, type of stimulant used, just cocaine or meth, primary route of use, IV, smoke, snort, might be multiple ways they use it, pattern of use, just as close as you can. Are they an everyday user, binge pattern, 3 times a week? Just get it in there, just give me an idea of how frequently they're using. Amount used per day, quarter gram, an 8-ball, depends. And then the date and the last time of the stimulant use. And then you go down to the questions. And these questions refer to how the client is feeling at the present moment. And again, we're giving them this scale and letting them decide. Do you feel irritable? No. No. Mild is a 1. Moderate is a 4. Severe is a 7. Do you feel sad? Slow to respond, but active. I'm moderately withdrawn. I'm withdrawn and unresponsive. That sounds like it's a subjective question. And I mean, that the counselor would answer. And I can understand it does seem that way to me too, but basically we're just going to ask them, do you feel sad? And just ask them to rate their sadness 0, 1, 4, or 7. Okay. We're just going to do the best we can with this question. Are your thoughts racing? That's purely subjective on their part. 0, 1, 4, and 7. Do you feel more restless or agitated than you are normally? Do you feel that things around you are not real or change in shape? So derealization can be part of a stimulant withdrawal syndrome. It starts to border on psychosis if they're really, things are changing shape. It's like a visual hallucination. Psychosis is much more associated with acute stimulant intoxication than it is with acute stimulant withdrawal. But nonetheless, we're going to just check in with that. Are they seeing anything? Are they feeling that the world is not real? 6, do you feel sleepy or drowsy? Pretty much everybody with stimulant withdrawal is going to feel fatigued. They've been up for 3 days or 3 weeks even sometimes. Do you feel nauseous? Have you vomited? And how did you sleep last night? Okay, and they're going to rank them all 0, 1, 4, or 7. Then we come down here. There are 8 questions. The max score is 7, or excuse me, the max score on each question is 7. So the max score would be 56. We're going to take their answers from up there for each one and just write them all in here. And then we're going to total it up. And then if this is the first scale, then these would be blank. But I do want the previous 2 scores to always be recorded. So you can just put the date here. Let's say this is their 3rd scale, and today is March 25th. So this would be like 323, or excuse me, 523 and 524. And then down here, this would be the score for 525. And so this allows me to see the trend. Which direction is it heading? Is it heading up or down, or is it staying about the same? Okay. Now it says here, note total score is indicative of increasing or decreasing severity of withdrawal. Scores are not directly linked to pharmacologic management. And that's because, again, these are subjective scales. The CWA and the COWS are directly linked to how much benzodiazepine are we going to give you, or how much buprenorphine or methadone are we going to give you. And that's not what's driving the administration of these scales. So that's just a note that they include on here. But it does, it gives us a definite idea of the severity and of the trend. Is it going up or down? Then you just put your name there and sign it and date it. Okay. Now the stimulant use disorder, these are sort of the directions for it. So we talked about the ones that can be the drugs that fall under this category: cocaine, methamphetamine, the prescription stimulants. Some people abuse Adderall, Ritalin, Concerta, Foca, the ADHD meds, and MDMA can all be used. We can use this scale with all those. And then here's the part about PCP. It's not exactly a stimulant. It's actually a dissociative anesthetic, but it is stimulating. It's can be very agitating for people. So it's a fair, it's fair to use this scale for that too. And then this information here is just about how long until we can transfer them to an alternate level of care. And if anytime, as soon as you give a scale that is without a report of moderate, which is number 4, moderate is number 4, as long as the score, I mean, the score, if it was all 1s and 0s, then they are ready to go to a different level of care. But we could also say if it's trended downward for 3 consecutive days, that it's okay to discontinue the scales and to get them ready to transfer to a different level of care, whether it's residential or IOP or whatever. Now, there may be some exceptions. They may be trending down, but they have extremely elevated scores. And if that's the case and you want to reach out to me, then we can make exceptions. And there will be times where we're going to need to keep people for 5 days, 7 days. It's definitely possible. But generally speaking, if there are no reports of moderates, or they have trended down for 3 consecutive days, generally speaking, with stimulant withdrawal, because it's not a clinically dangerous syndrome, that it's going to be okay to transition them to an alternate level of care. All right, so excuse me, we'll move on to the next one. This is the subjective opioid withdrawal scale, or SOWS. The other one we talked about, COWS, is the clinical opioid withdrawal scale. This is the subjective one. So it starts out the same: name, date of birth, date of the assessment, type of opioid, fentanyl, heroin, oxy, date of last use, primary route, they smoke it, snort it, take it by mouth. And then the client, again, is going to circle the most appropriate response for each of these symptoms. I also did include here, does the client use MAT for opioid use disorder? That's OUD, opiate use disorder. If they are using Suboxone or methadone, or potentially even Vivitrol, long-acting naltrexone, then you can just put, if they say yes, then put the name of the medication and the dose. Okay, because if they're taking MAT, particularly if they're taking Suboxone or methadone, it should ameliorate the withdrawal, right? I mean, if they do have some opiates on board, methadone and buprenorphine are both opioids, then their withdrawal syndrome should be less severe than someone who just goes cold turkey. So with the opioid withdrawal scale, I want to know if they're using any medication. Yes, no, and then put the medication here. That wasn't on the stimulant scale because there's no real medication for stimulant withdrawal. They might have some off-label stuff. They might have gabapentin or hydroxyzine to kind of help take the edge off, but there are no real stimulant withdrawal medications that are recognized. So in any case, there are more questions for this one. There are 16, and instead of going 0, 1, 4, 7, this is, as you can see, 0, 1, 2, 3, and 4. I like this one better. It's just a little easier when the numbers are consecutive. You don't have to make that jump, and the symptoms are more, they're just more obvious. So do they feel anxious? Not at all, a little, moderately, quite a bit, extremely. Do you feel like yawning? Are you perspiring? Are your eyes running, nose running? Do you have goose flash, shaking, hot flashes, cold flashes, muscle aches? Do you feel restless, nauseous? I feel like vomiting. My muscles are twitching. I have cramps in my stomach, and then I feel like using now, craving. So again, they pick them. 0, 1, 2, 3, 4, not at all, a little, moderately, quite a bit, extremely. You total it up right here, total score. And then again, you put the two previous scores. Again, if you were giving this scale on 525, this would say 523, and this would say 524. And same thing, just come down here and put your name, sign it. So with opiate use disorder, just some things, some guidance about when we can stop the scales and discharge them. If either of the following are true, their assessment is without report of moderate, which is signified by number 2, or their assessment has trended downward for 5 consecutive days. For the most part, if either of these are true, it's going to be okay to stop doing the scales and get them ready to go to a different level of care. Now, there will be exceptions. There could be someone who is shooting 3 grams of heroin and they go cold turkey and they have a 64. I've seen that plenty of times. There are people that are really, really sick, and 5 days later, they might be at a 60. So there are going to be times when we're going to make exceptions and keep people longer. So this is just kind of a guideline. But I would say if there's no report of moderate, if it's only 0s and 1s, they can leave. They don't need to stay. But the 5, there's some context for trending downward for 5 consecutive days. But generally speaking, that's going to be adequate. Okay, so we'll keep moving here. This is the short alcohol withdrawal scale. It's a subjective scale, and it replaces the CIWA, which is the clinical scale. And this one I also like to, because the numbers 0, 1, 2, 3, it's just when they're consecutive, it's a little easier than going 0, 1, 4, 7. But in any case, it's the same: 0, no symptoms, mild symptoms, moderate symptoms, severe symptoms. Again, we're going to give them the scale. Are you feeling anxious? No. Mildly anxious, moderately anxious, severely anxious. You have a sleep disturbance. You feeling restless? Are you feeling miserable? And that's kind of a little bit of a catch-all, but it's okay. It's part of the scale. Problems with memory, feeling confused, nausea. And then the 3 that are most significant are heart pounding, tremors, and sweating. Those are the most significant ones. If I see severe for heart pounding and severe for tremors, I'm going to call and check on them, okay? So you're going to total them up just like you did on the other ones. So put the total right here. Similar to the opioid, the SOWS, the subjective opioid withdrawal scale, do they have medication therapy to assist with the withdrawal process? Yes and no. And then if it's yes, you put the medications. Oftentimes it's going to be a benzodiazepine. It's going to be Librium, which is chlorodiazepam epoxide, or diazepam, which is also called Valium. But sometimes you'll see some other ones, chlorazepate, which I think is temazepam. Anything that ends in PAM, anything is a benzo. Chlorodiazepam epoxide, Librium is really the only one that doesn't end in PAM. But those are narcotic medications. They're controlled substances, and they are very effective for alcohol withdrawal. So we're going to see a lot of that. Some people use phenobarbital, which is also a controlled substance. It's a barbiturate. We don't see that as much, but that's very effective. And then there are a lot of adjunctive medications. Gabapentin is the main one. Which is, it has some seizure prophylaxis. It's weekly seizure prophylactic, but it really can help with the anxiety. And since we'll talk about this in another training, but since we're talking about it, benzos, they do hit the same receptor in the brain that alcohol hits. And so when you provide someone a tapering dose of a benzodiazepine, it allows them to drop off safely and greatly reduces the risk of them having a seizure or going into DTs. So I really want to know whatever meds they have, whether it's gabapentin or a clonidine is a blood pressure medication that can help with sweating. It can also help with tachycardia and with blood pressure, which can be associated with alcohol withdrawal. So I want to know all the meds they're on, but the primary one I want to know is, are they on a benzo? Usually diazepam, Valium, or chlorodiazepam epoxide, Librium. So just check yes or no there, put the name of the medication, and then again, put the 2 previous scores. And I'm just going to keep saying it for repetition. Today's 525. So if they came in on the 23rd, it should say 523, 524 with the score, and then today's score there. The max score is 30 on this one. And yeah, you're just going to sign it. Okay. So with alcohol use disorder, when can we stop the scale? And when are they going to be ready to transition to an alternate level of care? If the assessment is completely without report of moderate, which is number 2 up here. If it's all 0s and 1s, they're ready to go. You can stop the scale and get them ready to transition. if their assessment has trended downward for 5 consecutive days. And again, just a little asterisk next to that one, they're probably going to be ready. But if they had very severe withdrawal, I mean, they're, usually an older person that's been drinking maybe for a couple decades, they might have a downward trend for 5 consecutive days, but it might go from 25 to 23 to 21 to 19 to 18. And that's still fairly high. And we probably would not want them transitioning out at that point. But, this is just 5 is a pretty reasonable time to start thinking about moving them on. But we'll do it as a case-by-case basis. If people need to stay 7-8 days, then that's okay. All right, so the last one that we're going to talk about is the benzo withdrawal scale. Again, you start out client name, date of birth, date of assessment, the specific benzo they're using. And that's important because benzos have different half-lives. And the shorter the half-life, the more intense the withdrawal is. And Xanax has the shortest half-life. So Xanax withdrawal tends to be the most severe. But the shorter the half-life, it does make the withdrawal shorter. It makes it more intense, but it can also make the duration can be a little shorter too. But generally speaking, the shorter the half-life, the more intense the withdrawal symptoms are. So, and Xanax is the most commonly abused benzo, and that is because short half-life means fast acting. Xanax hits people the fastest, and that's why it has the greatest abuse potential. Things that have a longer half-life, like Librium and diazepam, they're not abused quite as much because they have a longer onset of action. And people don't like that. I mean, if you're abusing these, you want to feel it right away. You don't want to wait 3 hours until you feel it, like you might with Librium. So there's not really a black market for Librium. So the specific benzo does give us some information. Most of the time, people are abusing Xanax, Klonopin, and Ativan, most of the time. If they're abusing Klonopin or Ativan, it's probably prescribed. They probably have a physician that's prescribing it, or they're buying it from someone that has a real prescription, and it's actually pharmaceutical benzodiazepine. And I hesitate to say that's good, but at least we know what we're dealing with. If they're abusing Klonopin or Ativan, it's probably real Klonopin or Ativan. If they're abusing Xanax and they're buying it on the street, it's probably mostly fentanyl. There's not as much real pharmaceutical Xanax on the street anymore. There used to be a lot of it, but this Xanax now, it's a pressed Xanax. They call it pressed because when you look at it, you can see that it doesn't have that the profile of the impressions are not as professional. It crumbles more easily. And it might have some Xanax in it, but it probably has a lot of fentanyl in it. And of course, that's dangerous because of the potency of fentanyl. Fentanyl is 50 times more potent than morphine. So this discussion is a little bit outside of. We'll talk about it more in a different presentation. But I do want to know if it's the specific benzo, whether it's Klonopin, whether it's Ativan, or whether it's Xanax. And if it is Xanax, then also get some information. Is it street Xanax, or do they actually have a prescription, or do they know someone that has a prescription? And that gives us information if they're taking real Xanax or not. Okay, we'll talk about the pattern of the use: daily, a couple times a week, episodic, a couple times a month. The amount used per day, most people have been around a while. They know that the Xanax, comes in different prescriptions or different strengths: 0.25, 0.5 milligrams, 1 milligram. The 2 milligrams are called bars. That's what they call them on the street. So, they might say, I'm taking 4 bars a day. So that would be 8 total milligrams. And then we want to know the length of time using benzos, because the longer they use it, the more potentially worse the withdrawal syndrome will be. And then the date and time of last use of benzodiazepine. So this is another one where we're going to ask if they have MAT, medication-assisted treatment, to assist with the detox process, yes or no. And if it's yes, then we want to know what the name of the medication is. And the medications for benzo withdrawal, one of the main medications is benzos. we give benzos and taper them down. Phenobarbital, which I mentioned earlier, it's a barbiturate that also works. And then you'll see some off-label use of some things like Topamax, which is a mood stabilizer that's used in bipolar, usually bipolar 2. It's also a weak anti-epileptic medication. It's also used for migraine prophylaxis, but it can help with benzo withdrawal. Sometimes they'll use Tegretol, carbamazepine, which is another anti-seizure medication. Sometimes they'll use gabapentin. Sometimes, not very often, you'll see baclofen, which is a muscle relaxant. So whatever medications they've been prescribed to assist with benzodiazepine withdrawal, just include those medications and the dosages on that line. And if you have any questions, you can just reach out to me and you say, hey, is this a withdrawal med or is it for something else? So we get down to the questions. Now this one goes back to the 0, 1, 4, and 7. No, none, mild, moderate, severe. Again, I don't like it quite as much, but that's what the people who designed this scale came up with. So we just ask these questions. Do you feel nervous? No, mildly, moderately, or basically in a panic attack. Do you feel restless or agitated? Are you aware that your heart is racing? How did you sleep last night? Do you have a headache or feeling of fullness in your head? Any difficulty concentrating? And if you notice any change in your appetite? So they select the right score for them. There's 7 questions. 7 is the max score, or 7 is the max for an individual question. So 7 times 7, 49 is the max score. You're going to put that right down here. And again, you put the 2 previous scores right here. And again, gives us information about which way they're trending. All right. And then you just sign it. Some guidance for this one. You can stop the scales and get them ready to transition to a different level of care. If there's no report of moderate, which is the second choice here, or the third choice rather. So if they're all 0s and 1s and they don't have any moderates, then you can stop the scale. And if their assessment has trended downward for 5 consecutive days. This is another one where we will sometimes have to make an exception. Benzo withdrawal can go on for an extremely long time. The most severe parts of it are probably somewhere between 5 days and 14 days. With benzos, it's really that post-acute withdrawal that just goes on and on and on. It can go on for weeks and months. And post-acute withdrawal has a lot to do with the emotions and fatigue. There's depression, insomnia, pessimism. It's a lot of like psycho-emotional symptoms. And we'll talk about that in a different presentation too. But the real physical withdrawal is somewhere between 5 and 14 days. So I have down here, if they trend downward for 5 consecutive days, they are more than likely going to be ready to transition. But if someone's taking 8 milligrams a day of real Xanax, they might have significant physical withdrawal for 10 days. They could. So we'll kind of have to do it on a case-by-case basis, okay? But just this is some general guidance that downward for 5 consecutive days, a lot of the times it's going to mean they're ready to go. So just a few exceptions for the benzo and alcohol withdrawal scales. The opiate withdrawal scales and the stimulant withdrawal scales, again, because they're not medical emergencies, the guidance that's already been included is sufficient. But I just do want to spend a few more minutes here just talking about some exceptions with benzos and alcohol. So if a client's score increases from one day to the next, then I want the scale to be re-administered 12 hours later until 2 consecutive scales have trended downward. Okay, so they come in, their first score, I'm just making this up, on an alcohol scale we'll say it's 9. And then their next scale, the next day, you do another scale and it's 15. Then 12 hours later, do another one. And let's say that was 15. Then 12 hours later, do another one. If that is 16, then 12 hours later, do another one. But if it drops down to 14, 12 hours later, do another one. And if it drops down to 13, then you can go back to just once per day. Okay. And if that sounds like a lot right now, if it didn't make sense, it's okay. We can always revisit that. but just remember, if the score increases from one scale to the next, because initially we're just going to do these once a day, but if it increases from one day to the next, then we get them on a every 12-hour scale until we have 2 in a row that have trended downward, and then they go back to once per day. And then the clock really restarts at that point for for the length of time, like the 5 consecutive days, that sort of thing. That would sort of be their first day, that first one that went down. If a client's score increases twice consecutively, then I want them to go to urgent care. Okay, because that is a pretty clear indication that things are heading in the wrong direction. So if it increases from one scale to the next, we're going to go to 2 scales a day, and until we have 2 that decrease consecutively, then we go back to once a day. If the scale you give the first scale, and then the next one increases, and then you give another one 12 hours later, and it's increased again, they just need to go to urgent care, because that is, it can be an ominous symptom, or it can be an ominous predictor, and we just want to get ahead of it and not have them seize or go into DTs while they're with us. Okay. And so the last thing I would say is that I'm sure you're aware already of the 30-minute safety checks that have to go for a minimum of the first 24 hours. Ideally, they would go for 72 hours, but CDPH or DHCS rather, they do allow for the discontinuation of the 30-minute safety checks after as short as sorry, I'm not articulate right now. It could be as short as 24 hours that we're doing the 30-minute safety checks, but that's really going to be for people that it's just methamphetamine, or they just have a very mild presentation. But if we at any point during those 30-minute safety checks, but also at any point in their stay, the things that are the symptoms that we're really going to look out for, and particularly with alcohol and benzodiazepine withdrawal, that would prompt us to call emergency medical services are altered mental status, changes in behavior, confusion, or hallucinations. Okay. So, and these are things that they may not be reporting in these subjective scales. This means if the staff observes that, if someone's having an altered mental status, there's a really good chance they're going to lack awareness, and they're not going to report that in their scale. So if we observe them to have an altered mental status, their behavior starts to become disorganized or bizarre, they're confused, they're reporting hallucinations, we're just calling emergency medical service. If we notice they have difficulty with their balance or ambulation, and that's some, I mean, if it's prominent, if it's obvious, this person, we say they're ataxic. Ataxic means they're unsteady on their feet. If someone is visibly unsteady on their feet, they need to get medical attention immediately. If they are reporting that their heart is racing and pounding, we will have the capacity to check their heart rate, and that is in a different training, the interpretation of the vitals, but there are thresholds for tachycardia, for heart racing, that would also prompt us to get emergency medical services involved. Extreme tremulousness. This is going to be a little subjective on the part of the staff, but I mean visibly, if they were a wreck, if they are just visibly shaking, we're not the right facility for them. They need to get transported to the emergency room. Okay. If they hold up their hand and say, hey, look, I'm shaking, but they're actually able to, articulate that and demonstrate that for you, that's not what I would call extreme tremulousness. Extreme tremulousness is they're sitting across from you and they are just visibly shaking. Shortness of breath. If they're short of breath, we need to get emergency medical services involved. Chest pain. One of the primary cause of death in alcohol withdrawal DTs is a cardiac arrhythmia. So if they're detoxing from alcohol primarily, but even benzos and I mean, chest pain at any point, to be honest with you, at any point in their stay, but just with particular attention to alcohol withdrawal because of its association with cardiac dysfunction. So chest pain, fever above 103. People with real DTs can go, 104, 105. Recurrent vomiting or extreme nausea. If they're just throwing up nonstop, can't keep anything down, they need to be seen at the emergency room and get some Zofran and possibly get IV fluids. Significant agitation or panic, again, that's, panic attacks are associated with extreme anxiety, sweating. Oftentimes they get tunnel vision, lightheadedness. If someone is visibly angry and agitated and sweating, or they're visibly terrified and sweating, and then we're going to need to get emergency medical services involved. And the last thing is visual disturbances. If they are reporting visual disturbances, it could be a visual hallucination, which could also be part of DTs. Psychosis is also part of benzo withdrawal at times. Psychosis is part of stimulant intoxication. So if they're reporting visual or auditory hallucinations that seem out of proportion from when they initially arrived, if it seems to be getting worse, then we want to get emergency medical services involved. That one's a little difficult because we are going to treat people with comorbid schizophrenia, and some people have auditory hallucinations, particularly at their baseline. They just do. So we really need to use our judgment here. If someone is, claiming that they, are seeing, bugs crawling all over the walls or something like that, we're probably going to err on the side of caution and get them medical attention. Another thing about hallucinations with DTs, there's actually a tactile hallucination where they actually are hallucinating feelings, and it literally is bugs crawling on them. Often that's how it feels to them. Unlikely that we'd see that because that's really advanced DTs. But any hallucination we'd call it's a perceptual abnormality. So we just need, again, we need to use our judgment here. If it's something at baseline, if it's not out of character, out of their normal presentation, it's probably okay. But a acute onset of any perceptual abnormality, auditory hallucination, visual hallucination, tactile hallucinations, then we want to get ahead of that and get emergency medical services involved. Okay, so I know that I kind of went through that quickly. You're going to be able to review this as much as you like, and I will be available if you want to just reach out to me, staff. If you don't already have it, if you don't have it already, you can send me an email, and we can discuss this some more. So it's a lot of information. I don't expect you to digest it all right now, but just to kind of recap things. We're going to use these subjective scales. It's the client's report of their symptoms. It's substance specific, alcohol, benzo, opioid, and stimulant. If they're polysubstance abusers, we're going to use the hierarchy of the severity of the withdrawal to help us determine which scale to use. And again, that goes alcohol, benzo, opioid, stimulant. If they use alcohol and meth, we use the alcohol scale. If they use alcohol in heroin, we use the alcohol scale. If they use Xanax and heroin, we use the benzo scale. If they use heroin and meth, we use the opioid scale. The only time we're ever going to use the stimulant scale is if that's all they use, with the exception of cannabis. There is a cannabis scale, but we're not using it. So that's the hierarchy, which will allow you to select the right scale for them to use. And then we did talk about when the trends that let us know when we can stop the scale, when we can get them ready to transition to a different level of care. We talked about if it starts trending in the wrong direction, how we're going to handle that. We're going to increase the surveillance of the scales, and until they either start trending downward again, or if it goes up one more time, then emergency services get involved. And then lastly, just the specific things that may lie outside of the scales that would also prompt us to get emergency medical services involved. But again, that part will be part of another training, again, to look for things like shortness of breath and chest pain and those sorts of things. So I think that's what I want to say about everything right now. And again, just try to get as much out of this as you can. And If you are diligently applying the scales, you're doing a great service in helping us provide a safe environment for them to detox. And if you have any questions, you can reach out to the HSI leadership, but also to me. And once you start doing it for a while, you'll get very comfortable using them. And yeah, and it'll provide some really important information for us to guide their treatment. So again, thank you so much for your time, and I will see you on another training. Okay, bye-bye.